All right, guys. So this is going to be you just intubate the patient, and what do you do? So the first thing you want to do is you intubate the patient. You want to come over to the bag. You want to make sure your bag mode is on, right? Bag mode right here to the left. Close your pop off. So you get a little bit of pressure in the bag, and you're going to try and bag them a good 5 to 8 times. Nice big breaths. You're looking up on the monitor for end tidal CO2, and you want to see that it's actually consistent. Because if you're in the stomach, the end tidal CO2 is going to disappear after a couple breaths. There should be no CO2 in the stomach, but sometimes you ventilate the stomach when you're bagging them before you intubate them. So I do a couple big breaths. Look at this. Here's my volumes right here. I'm breathe, breathe, breathe. If the CO2 stays consistent, you're in the trachea. So now I'm good, right? Tube is over here. It's probably not taped yet. If you're smart, you have the tube tree on the patient ready to go. So after you intubate them, you can go hands-free and still have your tube somewhat secured. I don't tape the tube till I know it's in. So tube tree, I bag. Once I'm done bagging, the next thing I want to do is put the gas on. So you gotta put your gas on right away, or whatever your anesthetic is. I've bagged them a couple times. Open your pop-off so it's never just staying semi-closed with all this pressure, and put them on the ventilator, okay? So now they're on the ventilator. You want to come back, you want to tape your tube, make sure your eyes are taped. Check and see where your gas is, right? So I'm going to look up on my monitor, and if you notice something, I'm looking on the monitor and I don't see any gas showing up on the monitor. So this is a little interesting, right? The gas is turned on, but there's no gas up here. So first thing I did was confirm my airway's in. I bagged them a bunch of times to make sure that the end tidal CO2 up here is consistent. It doesn't disappear. I made sure my gas is on so that they're anesthetized. But I did notice that there's no confirmation that I have sevoflurane. So now I might, err on the side of caution and be considering giving some propofol boluses until I know what's going on. So I'm going to tape my tube. I think the orange tape here works the best. My eyes are taped with this tape or Tegaderms. And as I'm settling out now, the next thing I'm thinking of is, antibiotics, right? And I can start to change the vent settings and do the little things and stuff. But for the most part, the 3 most important things is, am I ventilating, right? And so I checked my ventilator. It's on a volume control, so I'm delivering. I'm supposed to give them 500. Am I getting close to 500 back? If you are, then you're ventilating okay. I should be able to see a capnogram here that shows that I have end tidal CO2 as well. But having this return to tidal volume is a good indicator that you're probably ventilating with the CO2. Now the sevoflurane showing up, so it was just taking time to calibrate. So am I ventilating? Is my gas on? Does it correlate with what I'm seeing for the gas register here? And then the third thing I always want to check, and you're always doing this, are my vitals stable? Is my blood pressure even cycling? If it's in manual mode, it is not automatically cycling. It could have been 10 minutes, 15 minutes since your last blood pressure. So you want to make sure this is automatically cycling. It's different everywhere you go, but make sure you're cycling I usually do every 1 to 2 minutes at the beginning of induction while you're busy, so you know when the pressure has dropped precipitously. But the 3 most important things: am I ventilating? Do I have anesthesia on board? Are my vitals somewhat stable, right? Heart rate, blood pressure, capnogram. If my EtCO2 is 20, it's probably because my pressures are in the tank. I doubt it's because I'm over-ventilating, because most of the settings, the preset settings, are low on these. Like this is set at 10 and 500. That's a low-minute ventilation. So a capnogram can tell you, or capnography can tell you right away if your blood pressure is up, high, or low based on how high your CO2 is. So the 3 most important things that you can do. So every time, every day, every 15 minutes, 30 minutes and stuff as a student, after induction's over, the other thing you want to consider doing, and you could do this after induction and intubation once your tube's secured, if you like to have a routine, you do what's called a left to right. Start at your left side, work your way around your entire anesthetic field here, and you want to check everything. Because when you're really busy and you're stressed out and there's a lot going on and your mind is running a marathon right now, it's good to just take a second, take a deep breath, and just look at everything and ask yourself, is that normal? Is that sufficient? Am I doing what I'm supposed to be doing? So if we start left, here's my IV fluids. A lot of times your IV fluids are wide open. So most patients could probably do okay with wide open fluids, but as you get busy and then you start to chart and you start doing other things, you could have a liter of fluid in depending on what the IV gauge is. So this is the time to be like, okay, I don't need this much fluid. I'm gonna gate down my fluid right now, right? The next thing I look at is the patient, right? Is the tube taped? Is it still at the right depth at their lip or teeth, depending on where you're measuring it from? Are their eyes covered? Is there anything on their face at all? Is their head actually on a donut? The donut helps alleviate pressure from the occiput, which can get pressure alopecia, which you can have hair loss. Is this underneath their head? Is it underneath their head? Are their ears is there pressure on their ears? Is there pressure anywhere in their head on something that's hard and stuff? Are my leads on, right? Is everything set up okay? The next thing is the tube. You should have the tube secured to something like a tube tree or tied off to the bed, because it's another safety point to avoid getting the patient being extubated accidentally. As you see with this circuit at Yale, there's no HME, so there's no humidifier on the circuit. So I would say you got to replace this with a humidifier, which in here we have them right here. Some circuits come with them already on, but you have to humidify a patient. Within 15 to 20 minutes, you start to see respiratory changes with that humidification. So it's really important. As I work my way to the right here, are my transducers at the phlebostatic axis? What's going on with the fluid over here? Is there any air in the line? Is my actual warmer on for the fluid? Is my patient have a bear hugger? Is that even turned on? You don't turn it on until the drapes are up. Now I get to the monitors. I look at my vitals. Are they normal? Are they even cycling? Do I have a change in the EKG from induction? Is my temperature on? That's usually always forgotten. You forget to put the temperature probe in. Just do it now. Don't wait. Is my anesthetic at a reasonable level? Is it correlating with what I have on the machine, on the vaporizer? I now check out my ventilator. So am I ventilating enough? We'll check the capnogram. Is my EtCO2 within a reasonable range? If it's high, you have to increase your ventilation. If it's low, check the blood pressure, but you might have to decrease your ventilation. So in this case, if you're doing volume control, you're going to adjust your tidal volume to 6 to 8 cc's per ideal body weight. And you want to now consider about turning down your flows. Once your anesthetic gets up to a reasonable level, it's time to turn down your flows. The higher the flows, and you want to turn down 2 liters or less with SIVO, or around 2 liters actually. And you probably want to add some air so you don't have absorption atelectasis from having 100% oxygen. And you can pretty much choose whatever your FiO2 is. Most people, there's no right number or wrong number in most cases. IA ratios we'll talk about. I like adding PEEP if they're stable and they've never had a bleb or spontaneous pneumos. It's nice to have a little bit of PEEP. A lot of the apnea and downtime with intubating induction, they de-recruit quickly. If it's a laparoscopic procedure, they're going to really need the PEEP. So I turn on some PEEP. The rest of the settings, I'll talk about in class when we do advanced ventilator management, but this is pretty reasonable doing 1-in-1, ventilating with ideal body weight for your tidal volume, and then setting your rate between 10 and 15 will get you probably through most cases, but you're really going to adjust these two settings based on what their capnography says. So if their EtCO2 is 50, you got to come up either on the rate or the tidal volume. If you're keeping the tidal volume within the 6 to 8 cc's, then your only option is to come up on the respiratory rate. As I work my way over, clean your workstation, organize it, have your stuff ready. SIVO again, is it actually going to run out? Or are you going to have an awake patient? And then when you get to the Pyxis and stuff, I like to keep this area clean, and I like to always have an extra syringe of propofol ready to go in case there's an emergency. One other thing that I didn't mention is as you start to run your machine, does your vaporizer turn to half or more purple? If it does, it's time to change it. When you change your vaporizer, that's a pretty big volume of air that's in there, right? So if you change your vaporizer, remember your vaporizer has the same amount of sevoflurane as your circuit does. So now if you change it with the new vaporizer, it's going to dilute your sevoflurane content in your circuit with just plain old nothing. So you're going to drop your sevoflurane levels when you change it. So you might have to increase your gas temporarily or increase your flows to help make up the difference of diluting the circuit with more regular air or whatever it is that you're delivering, whatever's in that vial, which is probably just room air, right? So just keep that in mind. And last but not least, are your vitals recording? In any major thing, you want to hit the buttons on the icons on Epic. So I really only care about you guys charting when you started induction, you did your intubation, and you did your incision. You can make quick notes or do little marks to mark important times like proning and stuff. But otherwise, you can always go back a half hour later, 20 minutes later, and chart everything. As long as you know the most important time frames by clicking either the quick note or those little mark now buttons, you're probably good. You don't have to focus on charting. It's going to distract you.